Well, I was involved in the Diversity in the City programme last year that Ambrose organised and invited me along to, and since I've been invited back again because presumably I said all the right things at that particular event. Today I'm here in my capacity as Equality and Diversity Lead, working for the University of Leicester, where I've been there just over a year now. In fact, I've just handed my notice in today. I'm going elsewhere, but not too far. Still doing equality and diversity work. Currently, amongst many things that I do, I manage our interpretation and translation service. So actually, this is a very pertinent subject area in respect of the services that we provide internally to our patients. That interpretation and translation service is to the value of £500,000 a year. The language part of it, as in the various languages that are spoken non-English within the city. In fact, we cover the whole of Leicester, Leicestershire and Rutland. Those languages are provided by an external provider called DA Languages. And DA Languages were the provider that won the contract back in 2017, August 2017. Although it took several months to actually get the service up and running because of the huge financial pressures that the trust is under. University of Leicester is not dissimilar to many trusts across the country. Many trusts that provide NHS services are under acute financial pressures. We have to manage all of that, and in fact my liaisons with the finance department, they wanted to actually ensure that we had financial controls in place to manage the budget, to manage the interpretation translation budget, to keep it under control so that we didn't spend more than we actually had to. The trust is currently £40 million in debt at the moment. With £40 million worth of savings we've got to make in order to break even. It's not an easy situation, but it does mean that actually it puts pressure in respect of providing services that meet the needs of our diverse patient groups. The DA Languages aspect of it, i.e. providing support for those patients whose first language isn't English, who need interpreters, is in the provision of interpreters, face-to-face interpreters, telephone interpreting, and translating documents. The British Sign Language part of it, I'm glad Martin actually mentioned that because it wouldn't have really featured in the talk that I was going to give today, but actually how can one forget the British Sign Language for our 2,000 or so deaf patients who cannot communicate other than in British Sign Language is provided by local providers, which wasn't the case back with the previous provider of language services, which was Pearl Linguistics, that actually went bust in February 2017, hence why we had to go back out to get a new provider of language services. Their provision was very poor to our deaf community, so we've got local providers, INET services, who are based at Frog Island, and Leicester Action Deafness. So why do we need to provide services for our multilingual patients? It may seem pretty obvious, actually. If we don't provide those language services, it means that patients do not understand very complicated, sometimes, medical procedures. They cannot give consent for treatment. It may mean that actually once they've been in for surgery, aftercare, if they don't understand their care plan, what they need to be doing, that can make them very seriously ill. We're in the business of improving people's health without ensuring that they've got equitable access to language interpreters and translation services, that they may end up with poor health. We, as part of our constitution, we have a duty to ensure that patients have choice, they're able to understand their care, they're able to make those choices, and they have the best outcomes in terms of their health. We also have clear legal duties under the Equality Act 2010 to ensure that people with disabilities and those from different racial groups are able to access equitably, to advance equality of opportunity, to eliminate discrimination, and to foster good relations between people. Okay. So they're the basic reasons why we have interpretation translation services. As I said, when the service first became operational, this current service, in February, the expenditure while we got the information out to service areas started at around £3,000 a month. It currently stands at £34,000 a month expenditure. Such is the demand. The languages that we cover will be quite extensive. I think in Leicester itself, according to some of the analysis that has been done using the census, we speak well over 50 languages. I wouldn't be surprised if it's close to 100 languages in the Leicestershire area. And the most commonly spoken languages that get accessed, it will not surprise you, top language is Gujarati. Then we have Polish, Punjabi, Hindi, Bengali, and then Arabic, and then you'll get other languages such as Kurdish, Turkish, Greek is one of the languages, and many of the European languages, Somalian, and I could go on. It is more tricky in terms of getting hold of people who speak less commonly spoken languages, because ultimately what it comes down to is that we need people who are not can only just speak the language but can interpret. So we need people who are qualified interpreters to be able to do that. With the British Sign Language, we need people who are actually at least level 6 qualified and have the competencies to be able to do the medical translation. And I've recently, very recently heard that in terms of people who are deaf-blind, that actually the service that's provided for deaf-blind people, which is Vista, our local providers of services, mainly to the blind and partially sighted service users, don't actually feel confident enough to translate into deaf-blind language medical terminology. I've only recently, over the last week or so, found out that alarming fact. It's not easy, it's really difficult in terms of ensuring that people do get the equitable treatment. I have been aware of instances where people haven't had interpreters. The first month that I started at University of Leicester, I heard a very disturbing story about a man who was deaf, who in the last week of his life didn't have access to a British Sign Language interpreter. So the last week of his life he wasn't able to communicate with anybody around him. And that is the shocking reality of how much it impacts on someone's life and quality of life, and it kind of underlines really how important it is that we're able to provide a 24/7 hour service, because we are a 24-hour service, 7 service. So I think that I'll kind of pause there and just give you some time to mull that over and think about that from a service perspective. It's not something that's a nice thing to do, it's a must do. And just to finish, actually, as I just remember, we've just recently reviewed our interpretation translation service. The Care Quality Commission, who actually inspect us on a regular basis, have told us categorically that family and friends should not interpret. They should not be used to interpret. And the basic reason for that is that you cannot guarantee that someone who's interpreting for a friend or family is going to interpret accurately and tell that patient what they need to know. So, for example, I was told by a speech language therapist about a man who came in with his friend who had terminal cancer of the neck. Brought his friend in to interpret. They didn't book an interpreter. The friend told the speech and language therapist later that he did not tell him that he was terminally ill because he thought it would be too upsetting. And that patient had a right to know that he was terminally ill. So, and it wasn't right for that friend to be interpreting for that individual. And one very, very last thing, just to add more more sort of layer on more complications, there are issues within the trust in terms of staff who speak different languages. We value staff who speak different languages in the trust because it enables them to be able to communicate if they can speak fluently with their patients, as you would expect. For example, if you go see your GP and you speak to them in English, if there is a Gujarati-speaking doctor or nurse who speaks fluently in the language, there's no reason why they cannot communicate in Gujarati with their patients. But there is an issue around staff speaking their own language, foreign language, to other members of staff in front of English-speaking patients. That is a big issue. And should we allow that? And does it impact upon patient safety because the English-speaking member of staff cannot understand what is being communicated between the staff who speak that other language? And I should stop there, just to give you something to think about.
You're sure? A little round of applause. So now you can see why we asked Haseeb to come. He's a fount of knowledge on local services and their relationship with language. Can I be